Up until probably the last 5 years on a broadly used basis, nobody was really assessing ocular inflammation. InflammaDry joined the armamentarium of ocular vital signs, which we now utilize on almost literally a daily basis, an hourly basis within the practice, to assess ocular surface status. So we look at InflammaDry or MMP9 to assess levels of inflammation and presence of inflammatory cellular activity. Additionally, we also take a look at the tear film, make sure that the tear osmolarity is within normal range, or if not, how that complements or enhances the ability to understand the relationship between that and inflammation. Eventually, though, the bottom line is the ocular surface becomes a vehicle for us to either lose compliance if we're not managing it well, to change the visual performance of the patient, and many patients complain about poor acuity because of ocular surface issues. They already have a little bit of a cataract. They may have some macular changes. So we need to optimize the external surface to maximize the residual visual performance capacity. And then the final piece is, at the end of the day, after 5 or 10 years of management, if the patient ends up in surgery, and it's highly likely that if they live long enough, they will move through medication, a good percentage, and move into surgery. I want the surface to be as pristine as possible so that when Rob sees them, he has the best opportunity to maximize his outcomes from a surgical perspective.
So I think we've all realized that inflammation's actually the problem in ocular surface disease. I mean, this research has been around since the early studies on cyclosporin, one of the first therapies we've had for reversing ocular surface inflammation. And so the information's been out there, but it's been hard to ever measure it on the average patient. Now we have a test like InflammaDry, which measures MMP9s, which basically this patient sitting in front of us, we can say where he's starting from baseline. And for me, I like to have that information before we even do anything or early in the process, and then measure change over time. If what we chose, number one, is not making the patient worse, or hopefully we see improvement if maybe we can do a therapy that gets the patients off of eye drops. So I think now we have tools in the office that we can use to assess more on an individual basis versus all, to put use in conjunction with study data, which talks about the general problem, and then we can once again measure how effective our therapy. The same thing that we do in lowering intraocular pressure. We get kind of a baseline, then we choose a therapy and measure how well we did after the fact. So that's what's, I think, really changed, and it's in the hands of all eye care providers.